start by thanking the organizers of this wonderful meeting in the delightful town of Córdoba. I've had a very good stay here and have greatly enjoyed the hospitality, so thank you very much. The topic I've been asked to address is preeclampsia and antiphospholipid syndrome. What is the evidence? So in a very brief way, I'm going to go through what I think the evidence is for the association between preeclampsia and antiphospholipid syndrome. Let me see if I can do this thing. Yeah. So for me, it all started before many of you were born. So you can see this paper here was published by Willem Lubbe, a cardiologist in New Zealand, in 1983. This paper published by our group in 1985, and this paper also published in 1985 by the group at Cornell, Dr. Michael Lockshin. And in these three case series of patients that we would now say have antiphospholipid syndrome, remember in the mid-1980s, there was no such designation. But as it turns out, in these several case series, the rate of either preeclampsia or placental insufficiency was substantial. Obstetricians wrote this paper. And so when we looked at our case series of only 8 patients, 5 of them during their pregnancy were delivered for severe preeclampsia. And 4 of those cases were delivered before 34 weeks gestation for severe preeclampsia, somewhat less frequent condition to be delivered early for the disease. Dr. Lockshin's paper, this paper focused on fetal distress as defined by abnormal fetal heart rate tracings, and the association between fetal distress and anticardiolipin antibodies. Poor fetal heart rate tracing in the setting of this kind of pregnancy is due to placental insufficiency in most cases. So these 3 small case series linked, in my mind, a relationship between preeclampsia, placental insufficiency, and antiphospholipid syndrome. Our group then went on to do a retrospective and prospective study of 76 patients delivered less than 34 weeks for severe preeclampsia. And and this is the 1980s, guys, we tested 43 of them for antiphospholipid antibodies. And 7 of the 43, 15% of the patients in our center in Utah, had either a positive test for anticardiolipin or a lupus anticoagulant. These were unselected patients. We didn't know that they might have these antibodies. Unselected obstetric patients. And so, by the way, 6 of the 7 were lupus anticoagulant positive. Fetal growth restriction leading to a small for gestational age baby occurred in at least one of the cases. And we emphasized that 3 of the 7 mothers had serious non-obstetric complications, thromboembolic complications. So for me, this locked in an association between severe preeclampsia and antiphospholipid antibodies. We then looked back at our cases over the prior several years, and that represented 82 pregnancies in 54 women, and 50% of the pregnancies were complicated by preeclampsia. 50%. Or fetal distress, think placental insufficiency. And severe preeclampsia occurred in a robust number, nearly 30%. 31% of the infants were small for gestational age as a result of placental insufficiency. So at this point in time, and this is around 1990, 1992, it was pretty convincing, to me anyway, that patients with APS had a high rate of preeclampsia or placental insufficiency. Patients with what we now call APS. It was a little less certain to me as to how the general obstetric population that might present with severe preeclampsia how much of the general population that might present with severe preeclampsia did or didn't have a syndrome that we now call antiphospholipid syndrome. Regardless, we got together in Sapporo, Japan in 1999 with Dr. Koike's hospitality, and we decided over beer that early delivery for severe preeclampsia or placental insufficiency should be added as an obstetric criterion for antiphospholipid syndrome. We reaffirmed this in the 2005 Sydney Congress hosted by Dr. Krillis. But this criterion was established, in my view, without good, high-quality prospective studies looking at unselected obstetric cases. And so in the early 2000s, one of my maternal fetal medicine fellows, Dr. Gibbons, designed and ran a prospective case control study of patients requiring delivery for preeclampsia with severe features or placental insufficiency. So we called it the PREPI study, preeclampsia placental insufficiency, the PREPI study. Mind you, in a funny twist of fate, the American College of OBGYN no longer calls it severe preeclampsia. They call it preeclampsia with severe features. I don't know why. That's what they do. At any rate, the only exclusion criterion was multifetal gestation. So anyone with a singleton pregnancy could be enrolled in the study if they delivered early for preeclampsia or placental insufficiency. We chose to include patients out to 36 weeks gestation, which is a different topic in a way, a different subject. And we ran the collection of patients during the dates seen. We defined preeclampsia with severe features according to our college guidelines, pretty good, solid definition. And placental insufficiency was defined by the features shown on the slide, and these are the features in the international criteria for APS. So the control population is very important here. We went to clinic and collected patients of a similar gestational age, collected patients with ongoing non-hypertensive pregnancies, of a similar gestational age and of a similar age. The primary outcome was the presence or absence of antiphospholipid antibodies, the classic lupus anticoagulant anticardiolipin, anti-beta 2. And you can see here that we ended up with 295 cases, and 148 of them enrolled in our study. So a little over half of the patients we approached for early delivery because of preeclampsia or placental insufficiency enrolled in the study. And we found at the University of Utah and Intermountain Hospitals in Salt Lake City, Utah, Northern European population looks just like me. Everyone there looks just like me, Northern European. We found that 11.5% of the cases, the PREPI cases, were positive according to international criteria for antiphospholipid antibodies versus 1.4% of the controls. To date, this is the best prospective acquisition of cases, unselected cases, that's been done. It's not a huge study, but it's 148 cases, and it's 10 or 11% versus 1 to 2%. And by the way, the 1 to 2% is in keeping with what I think you might find in the general population. We could discuss that at another point in time. 10 of the cases, 10 of the patients with the antiphospholipid antibodies had a small for gestational age baby reflective of placental insufficiency. So 10 is a lot, 10 of 17. Somebody's going to want to know, well, what about less than 34 weeks gestation? So 98 of the 148 cases required delivery prior to 34 weeks gestation, as defined in the revised Sapporo criteria. And positive antiphospholipid antibodies were found in 10% of those patients, compared to 1% of controls. The same numbers, essentially. So where are we? Patients meeting international criteria for antiphospholipid syndrome are at increased risk for preeclampsia or placental insufficiency. Those data come from case series. And that's typically despite standard therapy with a heparin product and low-dose aspirin, typically. We also know that a small proportion of patients without antiphospholipid syndrome previously diagnosed who require early delivery for preeclampsia or placental insufficiency are positive for antiphospholipid antibodies. I think the major contribution has been done by Dr. Gibbons and our group at the University of Utah in that prospective collection of cases. Now, this is an important point. Why? Well, if you have severe preeclampsia at 34 weeks gestation, 33 weeks gestation, maybe even 36 weeks gestation, your clinical management around the time of delivery and postpartum probably should be different. We should probably be thinking about thromboprophylaxis. It's also important to note that you've tested the patient this one time in a labor and delivery setting. Do they in fact have 12 weeks later antiphospholipid antibodies and therefore meet the criteria for diagnosis? That changes the patient's view of her health care into the future. But we need to do a lot of things, guys, and this is actually the message here. You can read the papers. You can read the papers. This is the message. We should better define the association between antiphospholipid antibodies and preeclampsia and placental insufficiency in larger prospective studies. I'd like to look at all patients, unselected patients, but also subsets. What about lupus patients? What proportion of lupus patients who become pregnant have this problem occur? And is it always linked to antiphospholipid antibodies or not? There are some data on this in the PROMISE study, but still, this is worth considering. Really important to this field is understanding this whole issue in terms of Black patients, white patients, Latina patients, and so on, because it's probably different in different populations. And we would do well to figure this thing out so we had a better handle on it. It's probably also very important to determine if low-titer antiphospholipid antibodies or isolated IgM isotype antibodies are associated with preeclampsia and placental insufficiency. And that would require prospective studies as well. And I think we should be wondering or considering if patients requiring delivery at any gestational age for preeclampsia or placental insufficiency should be tested for APS. Not to include them in research topics. Remember Dr. Erkin's messages yesterday. Not to include them in research, but for clinical care reasons. I don't have the answer because it would cost a certain amount of money to test all of those patients, but we ought to think about it if they have preeclampsia with severe features. Now, to do this, we have to collect early pregnancy samples on patients who are in for their first prenatal visit for booking. Got to collect the samples properly. Remember, you've got to spin the plasma for lupus anticoagulant testing. And if at the end of the day we find patients are positive, we must repeat the tests to see if they are confirmed positive 12 or more weeks later. This is a big deal. We need to do this stuff. There are advantages to obstetric studies, and we keep forgetting it. Most everybody comes for an obstetric visit in the first or early second trimester. Not everybody, but most everybody. They're going to have blood drawn anyway. Oh my gosh, here we are. We can store the plasma and the serum away in a freezer for a year or two. It doesn't matter, right? As long as it's collected properly. We will have, pretty easily in modern times, objective endpoints of interest recorded in the electronic medical record. It's easier to search for this stuff today, by far, than it was in the 1980s. So we can know when they delivered. We can know that whether they had preeclampsia or not. That's usually pretty well coded. We can know what their admissions labs were, what their platelet count was, what their AST was, what their ALT was. We can know the birth weight. That's pretty easy to get. And it's all over for a given patient in 10 lunar months. We need to do this work. And we need to do it in multiple centers, batch the samples, talk to core labs, and ask them to run the samples next year in big batches. It's cheap. Cheaper, I should say. Thanks for listening. I appreciate it.